the topic for today is CNS infections, and I will stick to the basics so that people are able to pick up between infections and other entities. So infections, they range from acute to chronic, indolent to life-threatening, and self-limiting to relentlessly progressive. So my outline will be that I'll be discussing the general principles, then we will discuss diffuse infections, focal infections, infections which are confined to the people who are immunocompromised, and some other entities. My outline will be, main focus will be on MRI. We will briefly touch the CT scan, the other things which can help our lumbar puncture and echocardiogram in certain infectious states, but I will not go into those details. My main focus will be on MRI. CT scan is performed initially when a patient presents with certain neurological symptoms, and with the help of CT, we can pick up hemorrhages, herniations, hydrocephalus, or mass effect. Why CT is performed in most of the centers is, number one, its availability. MR is not available in every corner of the country. CT is mostly available, so CT is performed as the first line of investigation. The other reason is that it is fast and it is easily accessible as well. The patient does not have to cooperate much for CT scan because it's a very quick examination. Now I will mainly focus on MRI because MRI is the investigation of choice on the basis of which we can differentiate between different kind of infections and between differentiating infections from tumors and infections from other entities like infarcts. So a very important sequence which we perform apart from T1, T2 and FLAIR images is the diffusion weighted image with ATC mapping. And also the post-gadolinium images, they also play a very important role. So here are two cases. The first row is case number 1 and the second row is case number 2. So if you look at the post-contrast T1 weighted image, which is the first image in the first row and the first image in the second row, you can appreciate that there is a kind of well-defined rounded lesion. One is in the right frontal and the other is in the left frontal lobe. On T1 post-contrast images, their characteristics are more or less same. They have peripheral post-contrast enhancement. These lesions are hyper-intense on T2 weighted images. They have some perilesional vasogenic edema around this lesion. So, but when you look at the diffusion weighted images, this lesion is showing central diffusion restriction and this lesion is not showing any diffusion restriction. So both of these patients were in their 50s and they presented with altered level of consciousness. So on the basis of this diffusion weighted image, we could decide that the first one is an abscess because the abscesses, they show central diffusion restriction. And the second one was a necrotic tumor with peripheral enhancement and no central diffusion restriction, some restriction along the periphery of this lesion, only along its posterior aspect. So diffusion weighted image plays a very important vital role in characterizing and differentiating abscess from a tumor. There are many times when tumors and abscesses, they mimic each other and it is very difficult to decide in those cases that what should be the management in that case. Abscess is an acute surgical emergency, whereas in tumor, you have to, do some other sequences probably, or you have to, you can consult the patient in a different way and the outcome is going to be different as well. So diffusion, if there is central diffusion restriction, like in this case, always consider an abscess. Peripheral post-contrast enhancement, hypointense T1, hyperintense T2, and central diffusion restriction. And if there is no diffusion restriction, then you have to think of other entities like a neoplastic lesion with central necrosis. FLAIR images are also very important. FLAIR stands for fluid attenuation inversion recovery. So it's a T2 weighted sequence in which the gray matter becomes white and the white matter becomes gray. But the CSF is not like T2, it becomes black. So anything which is showing pathological edema will not suppress on the FLAIR images. For example, in this case, you can see that there are multiple areas of FLAIR hyperintensity in the left frontal lobe, in the right occipital lobe, in the basal ganglia region, thalamic region. So this is something which is not suppressing. This is not normal fluid. This is pathological edema. That is why it is appearing hyperintense on FLAIR. So FLAIR is a very good sequence for showing pathological edema. If it had been a T2 weighted image, it would have been difficult to differentiate between normal CSF and pathological edema. So on FLAIR, the normal CSF is suppressed. These are important points. You have to keep them in mind that normal CSF is suppressed on flare images because it is attenuating fluid, as the name says, fluid attenuation. And if it is not suppressed, then it means that there is some dirty CSF or there is some pathological edema in this region. This is the same patient in which I showed you the flare images, the same patient, the same case, T2 weighted images of the same patient. T2 is a water sensitive sequence, so it has hyperintense signals both from the CSF as well as from the edema. So very few things, most of the things, they appear hyper intense on T2. That is, mostly there is edema in the things. There are very few things which are hypo intense on T2. For example, in this case, the wall of this abscess is hypointense on T2 weighted images. Similarly, the internal contents of this they are also hypointense on T2. So the caseation necrosis of TB, it also appears hypointense. Similarly, lymphomas, they have dense cell packing and at times they appear hypointense on T2. The fungus, it has got certain heavy metals which return low T2 signals, and similarly blood products according to their various stages and ages, they also appear hypointense on T2. So always remember that most of the things are hyperintense on T2. There are few exceptions which appear hypointense. Melanoma is one of them. I did not add because we are talking more about infections, but melanoma is one of the things which also appears hypointense on T2. So if you remember which things are low on T2, you will be able to, categorize the lesions quickly, because most of the things, they are hyper intense on T2. And if there is anything which is low on T2, then you have like 4 or 5 in your list. And by looking at T1, you can now differentiate that which entity this can be. T1 hyper intense structures, they are also very less. Most of the structures, they are hypo intense on T1 weighted images, that is like CSF or black on T1 weighted images. If there are hyper intense T1 signals, then you have to consider blood products, you have to consider calcium, you have to consider melanin, you have to consider fungus. Whenever there is enhancement in on post-contrast T1 weighted images, this shows that there is area of blood-brain barrier disruption. And the enhancement pattern, they can be multiple. The enhancement can be ring-like, the enhancement can be peripheral, it can be leptomeningeal or basal, for example. In this region, we can see that this is a ring-like enhancement. In this, you can see that there is peripheral enhancement, some of which is nodular and some of which is thin walled. Similarly, if you look at this image, you can see that this enhancement is dipping along the sulci and gyri, and this is basically leptomeningeal enhancement. This can be seen in cases of infections. This can be seen in cases of leptomeningeal carcinomatosis. So there can be multiple causes for this kind of enhancement, but you should be familiar with the enhancement pattern. So whenever there is enhancement of pachymeninges and arachnoid, that is leptomeninges, it is called leptomeningeal enhancement, and it dips along the sulci and gyri. Even this leptomeningeal enhancement or gyriform enhancement is seen in cases of subacute infarcts as well. So in that case, to differentiate between different kinds of enhancement and what can be the underlying etiology, we should be familiar with the history and clinical presentation of patient. And we have to look at MR scan in entirety. We can't conclude our findings of MR on the basis of a single sequence or single imaging plane. Remember that MR is a multi-planar, multi-sequential study. So you have to look at multiple imaging planes and you have to look at multiple sequences. You have to look at a lesion on T1 as well as on T2 and then on flare, and then you have to look at the lesion on diffusion and ADC, and then susceptibility weighted images, then post-contrast images. And then when all the information from every sequence is gathered, you place every information in the allocated place of jigsaw, and then the whole answer, at the end we get the whole answer. Similarly, this is another patient in which we can appreciate that there is a nodular enhancement along the basal meninges, the basal cisterns, and this is called the basal meningeal enhancement kind of pattern. It is mostly seen in TB and sarcoidosis. So there are certain patterns which are seen in certain clinical conditions, and we have to be familiar with them. So with this, we will move on to the diffuse infections. Mainly the diffuse infections include meningitis, then there can be encephalitis or ventriculitis, and there can be complications of certain infections. For example, if you look at this case, we can appreciate that the most common finding in cases of meningitis is a normal scan. Meningitis is basically a diagnosis which is based on clinical findings by picking up the signs of meningeal irritation and then confirming them with the help of lumbar puncture. So most of the times the MRIs can be normal in meningitis. But the importance of performing an MRI is that you have to look at the complications. For example, in this case, we can appreciate that there is enhancement along the leptomeninges of cerebral convexities. We can see that there is enhancement along the basal cisterns, and then there is some more leptomeningeal enhancement along the occipital lobes as well as the basal meningeal enhancement. So this kind of enhancement is not a normal finding. We can appreciate that there is the occipital horns are also a little plump. That shows that there is some development of early hydrocephalus. So these are the typical findings which you can appreciate.
Temporal horns, right?
Sorry, temporal horns. So these are the findings which you can pick up in a meningitis. The importance of MR, as I already emphasizes, is that we have to pick up the complications. For example, in this case, we can see that there is some attenuation of the MCA, and there was an infarction secondary to this meningitis, which resulted in vasculitis and caused infarction in this patient. The patient was 40 years old with headache and facial droop and slurred speech. So these complications are easily picked up with the help of MR. Similarly, this was another patient. This was the same patient, and one month later, there was an abscess which was formed in this patient, and you can see that there is thick enhancing wall. There is a compressed T2 hypointense rim. There is significant perilesional edema. The edema is vasogenic. It is not involving both gray and white matter. It is centered in the white matter, and there is central diffusion restriction. So there was development of an abscess in this patient later on. Similarly, in another patient who was an 81-year-old patient, this was a case of meningitis, and later on we could appreciate that on diffusion weighted images there was diffusion restriction in the dependent part of bilateral lateral ventricles. There was some fluid level, layering of some debris in the dependent parts, and this was a case of meningitis which led to ventriculitis. There was some enhancement as well, and there was some leptomeningeal enhancement in this region and on the other side as well.
डॉक्टर शुमाइला, आपको मैं डिस्टर्ब कर सकता हूँ एक सवाल के लिए?
Sure, बिल्कुल जरूर.
एडीसी इसमें कैसा नजर आएगा, या एडीसी हम लोग देखे ही नहीं?
एडीसी इसमें ब्लैक नजर आएगा. एडीसी बिल्कुल हम देखेंगे. देखिए, एडीसी इज वेरी इंपॉर्टेंट. वी कैन नॉट decide only on the basis of diffusion. I had limited. ADC is very important. Whenever there is diffusion restriction and those areas are low on ADC, that is true diffusion restriction. So we have to look at the ADC as well, and it is supposed to be low on ADC.
Okay. So then going back to your first जो आपने slide दिखाई थी, इसमें abscess versus, and I'm just, क्योंकि ये recording हो भी रही है.
This one?
ये बिल्कुल पहली slide दिखाई थी, उसमें आपने दिखाया था infection versus tumor का. तो उसमें ADC में क्या हम expect करेंगे?
ADC में भी हम यही expect करेंगे कि that would be low on ADC.
Okay. And so would be here.
And on this, the ADC will be bright because it will be following signals like CSF. The signals are similar to the signals in the leptomeninges. The CSF signals are followed in cases of tumor. So this is a central necrosis.
Right. So just to remember, हम देखेंगे फिर कि bright नजर आ रहा है DWI पर, और ADC देखेंगे तो black हो जाएगा.
So that would be an abscess.
और black देखेंगे अगर हम tumor पे तो वो bright हो जाएगा. That ADC पे तो that is more like a necrotic.
That is the necrotic element.
ठीक है, बहुत शुक्रिया. Sorry I've disturbed किया.
It's okay. It's better to clear the things there and then instead of gathering up the questions for the end, क्योंकि फिर वो slides पे पीछे जाने से बेहतर है कि it should be clear here. So with apart from meningitis, we can pick up encephalitis very well on MR. Encephalitis, especially herpes, we know that there is a typical distribution of the medial temporal lobes. It can be bilateral, it can be unilateral. There will be swollen cortices. We can, as we compare the right and left, it is very important always in brain to compare the right and left side. If you keep comparing both sides, you pick up so many pathologies very easily because your eyes can, your mind can compare the two sides, and you get a better justification of different things going on in the brain. So here we can easily appreciate that this size of sulci, they are not that swollen, but here it is a very swollen gyrus, and we can see that it is edematous as well. It has T2 hyperintense signals, and then it is showing diffusion restriction as well. And on coronal, we can compare the right and left side even in a better way. So this was a 46-year-old woman who presented with headache and behavioral changes. And basically, this was a case of herpes encephalitis. Definitely with lumbar puncture and rest of the lab investigations, they support our diagnosis, but we raise a high index of suspicion on the basis of imaging, because after that the investigations are certain investigations are generated. So it is very important to pick up all these findings on your MR. This is the same patient in which we could appreciate that there was post-contrast enhancement. It was in the medial temporal region, and then it was in the perisylvian region as well. And later on, 5 years later, this is the same patient in which there was significant atrophy in this region. And the patient developed later on fits because of this scarring. This was another case in which this was a patient who presented to our hospital after dog bite, and there were behavioral changes. And when we performed the MR, we found that there were bilateral hyperintense basal ganglia, and there were some hyperintense signals in the midbrain as well. There was no diffusion restriction. There was no post-contrast enhancement. So this was basically a case of rabies encephalitis. With this, we move on to the focal infections. And in focal infections, they can be either walled-off infection like
मैं सॉरी आपको इंटरप्ट कर रहा हूँ. सो कोई ऐसे की फीचर्स जो एनकेफेलाइटिस को बिकॉज न्यू स्टडी की प्रैक्टिस में क्लिनिक में पेशेंट आता है तो टू बेटर अवॉइड बायोप्सी उनको लो ग्रेड ग्लाइड लीजन समझ के, तो कोई ऐसे की फीचर्स है जो ट्यूमर से डिमार्केट कर सकें, हम याद रखें एनकेफेलाइटिस.
Okay, for example, in cases of herpes, like I showed you, if it had been a low-grade tumor, there will not be this much diffusion restriction, and there will not be this much enhancement. So it is obviously not a low-grade tumor. If you will consider a high-grade tumor in this case, so there is no typical, we know that the tumors, they have their certain locations and certain appearances. Mostly the tumors which are in the region of temporal lobes, they are either DNETs or they are MVNTs or they are gangliogliomas. So they are all low-grade tumors. We don't see much high-grade tumors in temporal lobes, and the low-grade tumors, they have typical imaging appearance. They are like DNETs, they are bubbly in appearance. MVNT, they have tiny vacuoles, tiny cystic areas in them. So it does not, follow the same MR pattern on in this case. The only thing which can come in the differential of this is an infarction, because an infarct can present like this. It can appear to be swollen. It can show diffusion restriction, and it can follow even this. This appears to be territorial as well. But in that case, you have a clinical spectrum. The patient had sudden behavior change. There was no focal neurological deficit. She had headache and behavioral changes. So it's actually the same which I described previously, that you have to, keep every piece of information at its place. Otherwise, you stay confused. Then the people who do not have every single piece of information while reporting, they give a long list of differentials. If I did not have, I will not say myself, if any other radiologist did not have any, information about this patient, and mostly it happens in private centers that the radiologists, they are given the scans and they have to report without any history, without any clinical information. So then the report is like a long list of differential from a differential book. So for that, you have to have a close collaboration with your radiologist, so that you give the clinical information, you give your piece of information, and then we, on the basis of that, we give our piece of information, and then that helps the patient. Otherwise, if randomly such kind of a scan will come to you, you will write that it can be infarction, it can be tumor, it can be encephalitis, because you don't have the clinical picture. So having a clinical picture is very important. In this kind of appearance, tumor is unlikely, because the tumors which are typically involving this region do not have this kind of appearance. Infarction is a close differential, but knowing the history that there is no deficit, and then we have a follow-up scan, and then we have a later follow-up scan, and then we have the lumbar puncture of that patient. So we do with the help, additional pieces of information. I
Thank
hope it
you.
answers your question.
Thank you so much.
Similarly, in this case, we knew that the patient had a history of dog bite. So if we did not have the history, we would have, toxic, metabolic, and we would have given a vague report. But having a history and, incorporating your findings in the light of that clinical spectrum, it becomes very valuable. So focal infections can be walled-off infections like abscesses, as we already discussed. They can be parenchymal, subdural, or epidural collections, and they can arise either from local infections or from hematogenous. This was a patient who presented to us with this focal abnormal signal intensity area, which was hypointense on T1 weighted images with some peripheral post-contrast enhancement. The patient initially had a scan from outside JPMC, and at that time, that scan was performed on a 0.3 Tesla scanner, so no diffusion images were available at that time. So the patient was given, was reported as a case of thalamic glioma, and then the patient came to us for the opinion of CyberKnife. And when we performed the full study here, we found that there was diffusion restriction in this area, and it appeared low on ADC map. So here we have diffusion and ADC both. And there was a compressed rim on susceptibility weighted images. So this was basically a case of thalamic abscess. Later on, it was operated in the neurosurgery, and it was found to be a bacterial abscess. We labeled it as abscess, but with the help of post drainage, we found that it was a bacterial abscess. There were no certain features on the basis of which we could decide, but mostly bacterial abscesses, they show diffusion restriction. It is not mandatory for tuberculous or fungal abscesses to show diffusion restrictions. Tuberculous abscesses, they mostly have central T2 low signal because of caseation necrosis, but it is not exclusive. It can be in most of the cases. This was another patient, 45 years old, alcoholic, presented with vomiting and difficulty in walking. The patient had a CT scan in which it was found that there was some breach in the cortex of mastoid. And this was appreciated on these images as well. There was some hypodense area involving this. And when MR was performed in this patient, it was found that there was a large abscess in the right cerebellar hemisphere, which was showing diffusion restriction, and it appeared low on ADC mapping. It had a hypo-intense compressed T2 weighted rim. There were fluid signals within the mastoid ear cells. It was hypo-intense on T1, and there was thick nodular post-contrast enhancement. So this was another case of an abscess, which was due to focal mastoiditis, which resulted in extension in the intracranial cavity. This was another patient in which there was a subdural abscess, which showed peripheral post-contrast enhancement and diffusion restriction. So it was low on ADC map as well. So there are certain infections which are seen in immunocompromised or immunosuppressed patients, like patients of HIV, lymphoma, leukemia, patients on chemotherapy, diabetic patients, and pediatric age group. So especially in HIV patients, there are two very important entities which appear as white matter hyperintensities, and these are HIV-induced encephalopathy and PML. So they are very similar in appearance. This is a case of HIV encephalopathy in which there are bilateral symmetrical white matter hyperintensities, and this is a case of PML. So PML is basically a reactivation of JC virus. The difference is that in PML, there are asymmetrical subcortical T2 and flare hyperintensities, and these are non-enhancing. And in cases of HIV encephalopathy, they both share some same features, but both cause confluent white matter lesions without significant mass effect, but more peripheral and asymmetrical in PML. As they appear the oligodendrocytes, they infect the oligodendrocytes more, but they are more central and symmetrical in HIV encephalopathy because they infect the microglia. So it is an important thing to remember. So whenever a patient, both of these patients had a CD4 count of less than 200. Unfortunately, in past 3 months, I've seen so many cases of HIV in our hospital who are presenting from interior Sindh, and they were all young males in the age group of 22 to 32, and they presented with CNS symptoms. And when their brain was imaged on MR, we could find so many odd infections that led to their that led to this idea that we should get their HIV workup. And when their HIV workup was done, they were found to be HIV positive, and most of them had their CD4 count between 100 to 200. So I have seen at least 10 to 12 such cases in past 2 to 3 months. And I don't know how many we would have missed, how many would not have presented to the hospital setup. So it is important to pick up these things. Similarly, another important thing which we should know in immunocompromised is the differentiation between toxoplasmosis versus lymphoma. So toxo is mostly multifocal, and their most common location is basal ganglia. They do not show any diffuse restriction on DWI. They make a target sign. There is a central enhancing dot. Whereas in lymphoma is also very common in HIV. The lymphomatous deposits, they are hyperdense on CT. They show restricted diffusions in areas of enhancement wherever there is dense cell packing. The areas which show enhancement, they also show diffuse restriction. They are more solid, they are more periventricular, and they are thallium hot, and they are steroids responsive. So this is a case of toxoplasmosis in which we can see multiple lesions. And if you focus on this individual lesion, you can appreciate that there is a central enhancing dot, and there is a central enhancing nodule in this as well. And this is typical of toxoplasmosis. And they do not show any diffuse restriction. You can see that this large lesion is not showing any diffuse restriction. It is different from lymphoma, in which you can see a peripheral solid enhancement, and this enhancing part shows, this is periventricular, and this enhancing part shows diffuse restriction. Another very important thing which is seen in HIV patients especially is cryptococcus. And always remember that in cryptococcus, there are multiple gelatinous looking tiny cystic lesions in the region of basal ganglia. So this was another case of HIV. Patient presented with headache, and the cryptococcal antigen was found to be positive. So these pseudocysts or gelatinous cysts in the region of basal ganglia, they should raise the possibility of cryptococcus. And then obviously lumbar puncture is going to give us further evidence to confirm our radiological diagnosis. Other two important things which are the last to discuss are cysticercosis and CJD. So in cysticercosis, it has various stages. You all know that the chronic is calcified, C for chronic and C for calcified. So if there can be old calcified lesions on CT, there can be thin walled cysts with a dot or scolex inside. Their walls can enhance, and they can have surrounding edema. This is another case of cysticercosis, in which we can see that there are tiny T2 hypointense areas with perilesional edema. And then there is peripheral nice ring-like enhancement. They can have low signal on T1 and on T2 weighted images, and they can show dropout on susceptibility weighted images, which is secondary to calcification. They can have a variable amount of edema. These are the different stages. All of you must be knowing about them. I'll not go into their details. Similarly, CJD is a very important disease, especially in patients who present with rapid dementia and rapid decline in their neurological status. One should consider CJD whenever there is diffuse restriction in the region of basal ganglia, in the region of pulvinar of thalami, and there is this cortical ribbon sign. So whenever you see cortical diffusion restriction or cortical T2 weighted hyperintensities, basal ganglia show hyperintensity to and flare signals or diffusion restriction. And then this is pulvinar or hockey stick sign in the region of medial thalami. Always consider CJD or prion associated disease. So to sum up, whatever I told you, conventional MR, T1, T2, T1 post-contrast are very important sequences. The lesions can either be ring enhancing, they can be in the region of basal ganglia, they can appear as gray matter hyperintensities like in cases of encephalitis, they can appear as white matter T2 hyperintensities like in cases of PML or hive. The ring enhancing lesions, at times MR spectroscopy as an additional investigation is performed. up to the best of my experience, MR spectroscopy do not add very much to my baseline imaging information. But most of, as far as my experience with our neurosurgery colleagues at JPMC is that their books emphasize a lot on MR spectroscopy. Our experience is that it is not a very good additional, it does not provide a very good additional information, but there can be absence of choline because choline is part of normal cell membrane. So whenever there will be necrotic tissue in cases of abscesses, there will be absence of choline. There can be lipid lactate doublet in cases of internal areas of necrosis. And there are some other metabolites which we do not perform. These metabolites, their integration is not available in our scanners. Then the ring enhancing lesions, at times they can have a complete smooth hypointense Raymond susceptibility weighted images, which shows the wall of abscess, as I showed in case of that thalamic abscess case, which I shared initially. Similarly, these are different tables in which, with the help of which, if you want to keep their screenshots or this lecture will be recorded, you can at least characterize that. What is the appearance on different sequences, and on the basis of that you can
Where does perfusion scan come in that? Do you any thoughts on that one?
Perfusion scan can help you in categorizing between tumor and abscess. There can be some peripheral perfusion in cases of abscesses due to increased vascularity and increased inflammatory response. But perfusion scan as a problem-solving tool is not very helpful. As a problem-solving tool, we need diffusion. Diffusion is far superior than perfusion. Perfusion is helpful in cases where we are concerned about tumor necrosis and tumor recurrence, and that is other than infection. That is a different topic other than infection.
Right,
so perfusion does not play a lot of role in cases of infection.
Okay, thank you.
You're welcome. So this is one of the cases from my department. 22 years old girl with low-grade fever, headache, gait disturbance.
सवाल पूछ रही है ना? Are these test questions? Yeah,
do
you have a lot of slides left?
I did not add much of the questions actually. I just kept, because it was so extensive. So and the previous,
if you have a lot of slides left, तो फिर तो चलती रहें, लेकिन if you not, then
no, if we do not have, we do not have much of the slides. It's about to end. So
Mushtaq,
okay, fine. You can, one of you can explain that which sequence is this and what are the findings.
So I'm randomly Dr. Faizan. Could you please answer the question? Your differential.
I mean, अभी तो खाली sequence पूछ रही हैं Dr. Shumaila.
I am just asking about what sequence is this, and can you appreciate anything?
अच्छा मैं बता देता हूँ. So basically a T2 weighted image, and here we could see the multiple patchy subcortical hyperintensities in the white matter area.
Okay. So subcortical is a different place, and white matter, so it's better to call it that it is in white matter, right?
Okay, ma'am.
So please explain this as well. All of you can participate. It's okay to make mistakes.
So
we make more mistakes than you ever know, actually.
Yes, exactly.
So is it all the same?
Actually, when you make a mistake, you never forget that thing for the rest of your life. So it's okay to make mistakes.
So, madam, another T2 weighted section, and here you could see in the posterior fossa there's a large cystic lesion, and which is hyperintense central and peripheral hypointensity, and it's causing lesional edema, effacement of fourth ventricle. And so this cystic component, there are two lesions basically, and anteriorly we can notice hyperintensities at the area of cerebellar peduncles, and brain stem is pushed forward.
Right, good. So this is the same patient, T1 weighted images, and post-contrast T1 of the same patient. So
axial cut T1 weighted image. So at the occipital region, we can notice that irregular hyperintensity on particular bi-occipital area, and it's showing minimal enhancement, basically small ring-like enhancements which are basically found in the right occipital area.
So basically it's a cluster of ring enhancing lesions, right?
Yes.
And this is the lesion in the posterior fossa, which you already explained on T2. Apart from the two lesions, you can see that there are multiple other clustered lesions. So if you go back to your T2, you can appreciate that there was some area here which showed T2 hypointensity. So basically this is the caseation necrosis, which is hypointense on T2 weighted images. So there are multiple lesions, and these are the different weighted images. So what are your findings?
So in a posterior fossa, again, there are multiple lesions which are showing rim enhancement, and also showing diffusion restriction.
Yes.
So I think this could be tuberculous abscesses.
So if you look at this, that this area which is hypointense, which has a central hypointensity, hyperintense on T2 and shows peripheral enhancement, it is showing diffusion restriction. But these lesions, only their periphery is showing restriction, these lesions which were low on T2. So there are tuberculous abscesses as well as there are tuberculomas. So there are two different things going on. So probably on the basis of this restriction, you can decide that this lesion should be decompressed, and rest of the lesions, they will respond to ATT.
Nice, thank you.
So
would you agree there's a pachymeningitis as well? They look very thickened and enhancing.
Yes, there is that is not pachymeningitis actually.
Yeah.
That is
It's
post
thickening,
LP.
yeah.
The patient had lumbar puncture basically. So secondary to lumbar puncture, the pachymeninges, they show a little enhancement, but it is a very smooth kind of enhancement. So
Do you have a
I will not call it.
Do you have a separate word for that, pachymeningitis, because of infection versus meningeal enhancement? Because of
It's not pachymeningitis. It's smooth enhancement of the pachymeninges, but it was a post LP patient, so I will not call it. Mostly pachymeningitis is not seen in cases of meningitis. Mostly we see leptomeningitis. Pachymeningeal thickening as part of infection is, it's not a typical thing which we see in routine. Pachymeningeal nodularity and enhancement is seen in cases of either it is post LP or it is secondary to some hypoglycemic, hypotensive insult. It is not seen in cases of infections a lot. Mostly we see leptomeningeal enhancement.
So the standard word is pachymeningeal thickening. That's what we call it.
Yes.
Pachy का मतलब है हाथी. So हाथी means thick. So pachy is thickening and meningitis obviously is meningitis.
Right. So this is not pachymeningitis.
No.
It's what we call it, pachymeningismus, pachymeningeal.
It is prominent pachymeninges, like dural prominence or dural thickening, but it is pachymeninges is basically dura, right? So dura is very tough. It gets infected very late. It's not that easy to infect. So this was another case, 55 years old male, fever, presented with fever, altered level of consciousness and weight loss. So who would like to take this case?
Anyone from residence? So I think Dr. Daniel is willing to comment on it.
Wonderful. Daniel, आपके लिए तालियां. हिम्मत किया. Good.
So this is the T1 weighted image of the MRI brain without contrast, which is showing the hypointensity in the right parietal region, along with this circular ring-like enhancement with small amount of midline shift also.
Okay, you can use the word of subfalcine herniation in this case as well. So there is correct, you explained very well that there is a T1 weighted hypointense area in right frontal region, which is causing significant effacement of the ipsilateral lateral ventricle, and there is some associated midline shift or subfalcine herniation. So On T2 weighted images, you can appreciate the same findings, except that the central area is hyperintense. There is some T2 low signal area here. So now explain the post-contrast findings.
G. This is the T1 post-contrast sequence, which is showing the multiple ring enhancing lesions on the right parietal region, along with significant midline shift. So there are multiple enhancing lesions, 1, 2, 3, 4, at least 4 ring enhancing lesions.
Okay, there are multiple, right? More than 4 actually. And there is some leptomeningeal enhancement as well, which is very subtle, but it is there. So this is the same area shown in sagittal planes. What is this sequence and what are the findings?
This is the DWI, which is showing the diffusion restriction of the same lesion which was seen in the T1 post-contrast.
Okay. And what is this sequence? This is the ADC map, right? So this is diffusion and this is the ADC map. So all the areas which are showing diffusion restriction, they appear low on ADC map. And the surrounding vasogenic edema, it appears hyperintense on ADC map. So these are the susceptibility weighted images, and you can see that there is a compressed rim along this large abscess. So this was a case of bacterial abscess. So these are flow charts which I have just kept for the sake, if you want to characterize different basal ganglia lesions on the basis of diffusion, perfusion, spectro, and gradient. They are available on the internet everywhere. Similarly, if you have gray matter hyperintensities, you have to categorize between encephalitis and infarction. How will you differentiate between different? You can keep these flow charts with you. They can be helpful. This was another case of
इसका वो बना सकते हैं एक कलर कार्ड बना के उसको लैमिनेट करके हम लोग बांट दें. I don't know. I mean, I'm old fashioned, so असल रेजिडेंट्स को फायदा होगा कि नहीं होगा?
So रेजिडेंट्स को तो मोबाइल पे फायदा होगा जिस पे ज्यादा होते हैं.
जमाना गुजर गया. ठीक है.
जी वो जमाना गुजर गया. This was a case of dengue fever, and this patient presented to us with altered level of consciousness, and there was bilateral symmetrical hyperintense signals. I have seen a lot of presentations of dengue in recent month. There was a presentation similar to West Nile virus in which there were bilateral thalamic infarcts. There were areas of encephalitis. I have seen similar cases, similar appearance in case of dengue as well. Recently, there were 2 cases who presented. One had bilateral thalamic signals without hemorrhage, another had bilateral thalamic signals with hemorrhage. So dengue is showing a lot of variations in its presentation. There are cases in which there are subdural and epidural hemorrhages as well. So this is a table which shows MR findings in cases of different encephalitis. What are the typical areas of involvement in case of herpes simplex, in case of Japanese encephalitis, West Nile and viral encephalitis, rabies encephalitis. So if you want to keep this table with you, that is also very important. So with this, I will conclude my talk of today by giving you a small take-home message that recognition and characterization of central nervous system infection poses a formidable challenge to the radiologist. Imaging plays a vital role, the lesions typically being, which are being readily inaccessible to tissue sampling. The results of an accurate diagnosis are endlessly rewarding given the availability of excellent pharmacological regime and the availability of numerous MR sequences which provide functional and molecular information is a powerful tool in the hands of the radiologist. However, the plethora of sequences and possibilities of each sequence is also intimidating and often confusing, especially for our clinical colleagues because they are not, very familiar. Most of them are not very familiar with MR reading. So a helpful learned radiologist colleague, they can be a savior to your, diagnosis. So with this, I will conclude my talk and thank you so much. I can be contacted on this email address in case